So good evening, everybody. Welcome to another session of Thoracic Gurus. And we are fortunate today to have Vikas Keshri, who, as we know, is our beloved teacher and a senior consultant at in cardiothoracic surgery at Max Super Specialty Hospital, New Delhi. And he has taken a lot of initiatives and done a lot of lectures for us. And this is actually the third in a series of lectures on mechanical complications of coronary artery disease. Dr. Vikas, take it away.
Good evening, everybody. Thank you, sir. So at the outset, I would like to thank our beloved AGK sir for allowing me to be presenting on this forum. And I would like to thank all my groups. These are the places where I work and from where I have gained a little bit of knowledge. And at the outset, I would like to say this is just meant to be a session for revision just before the examination. This is not how I do it. This is how we are supposed to answer in the exams. So these will be like mostly like notes and not flamboyant series of technical videos or other things. So this is only basic theoretical and practical knowledge for exam and also for real life situations. So we'll start from where we left. So we have seen other portions. We are now discussing patients with mechanical complications of myocardial infarction, and we have done the post myocardial infarction, ventricular septal rupture, and pleural rupture. We have seen ischemic mitral regurgitation. These videos are available on the YouTube Thoracic Guru channel. So those who want to refer back or those who have missed it can make it useful. So today we'll be discussing left ventricular aneurysms. So starting with, so what is the definition? What we mean when we say it's a left ventricular aneurysm? So it's a transmural delineated area of fibrous scar in the ventricular wall, which is devoid of any cardiac muscles and trabeculations. So this is important. There are no cardiac muscles and no trabeculations in the left ventricular aneurysm, and this is due to replacement with hyalinized fibrous tissue. So by definition, pathological specimen, if we find, we will find that the area has become smooth, and it may be either akinetic or dyskinetic, and it is always associated with decreased ejection fraction. So this is a complete definition for left ventricular aneurysm. It's a transmural delineated area of fibrous scar in the ventricular wall, which is devoid of cardiac muscles and its trabeculations due to replacement with hyalinized smooth fibrous tissue. And this may be either akinetic or dyskinetic, and it is almost always associated with decreased ejection fraction. So that is a difference between scar and an infarcted area. So in an infarcted area, we still have trabeculations. We still have some cardiac muscles which are dead. In a aneurysm, we don't have any cardiac muscles. It is just a fibrous tissue which has become thin. So a scar will be thin, devoid of any trabeculations, and it will be a completely delineated area. So, and there is no, by definition, there is no hibernating myocardium in this in the left ventricular aneurysm. So all the surgeries for left ventricular aneurysm, when we are speaking, by definition, we are telling that we are operating on the tissue which is a dead tissue, not a dead tissue, we'll call a fibrous tissue devoid of any hibernating myocardium also. So angiographically, it will be a segment of LV which is protruding from the expected outline, and it may be either akinetic or dyskinetic. And when we are operating on this heart, it will be a thinned out scar which may be adherent to the pericardium. And how we identify intraoperatively on the table that once we vent the LV, that area will pucker or collapse. So that is the area which we are going to excise. That is the area which we are going to address. That is the area which is become aneurysmal. So akinetic is that segment which does not move during systole. So when the remaining part of the heart is going in the systole, going inwards, this area will not move. So that is akinesia. In dyskinesia, there is paradoxical movement. The remaining portion of the heart is contracting, but this part is bulging out. So that paradoxical movement, and the boundaries are defined by this transition from the thickening and thinning portion. We'll see there is some significance of this. We'll see in coming discussion. So about epidemiology, the incidence varies from 10 to 35%. Why the incidence is so? Why there is such wide variation in incidence is because earlier studies, the definitions were not very well defined. So some studies had taken some other definition, some other studies have taken some other definition. And as we have progressed in our understanding and management of coronary artery disease, so there is early revascularization and reperfusion therapies now. So that is why incidence in newer studies will always be less than the older studies. So this is decreasing because of reperfusion, and hypertension is now better managed, which is a risk factor for development of aneurysm. So that is the reason the newer studies, they give lower incidence. Uh, the older is, which is quoted in all the text, is data from CAS study, coronary artery surgery study. So here they had found that angiographically detectable left ventricular aneurysm is present in up to 7.6% of patients with left ventricular aneurysm. And of these, less than one third have a single vessel disease. So most of these patients in the coronary artery surgery study, they found that left ventricular aneurysm is associated with multiple vessel disease, which is a contradiction with post-MI VSD or post-myocardial VSD or myocardial rupture, which occurs most commonly in patients who have single vessel disease. And it is common in those patients who had a history of prior myocardial infarction. This is again contradiction from the other mechanical complication, which generally occur in patients who have the first myocardial infarction where collaterals are poorly developed. So 50% of them occur in 48 hours, and almost all are seen within 2 weeks. And they may continue to enlarge for 6 months, but once we have crossed 1 year, the enlargement is not seen. So they do not enlarge beyond 1 year. So then in the pathophysiology, we always listen true aneurysm and pseudoaneurysm. This is same as any other vascular. So a true aneurysm will have all the three layers of the cardiac wall. So whole of the wall, both the walls will be bulging. So it will have a wide base. Wall will be composed of myocardium or the scar, and there is a lower risk of rupture. Compared to that, if we have a pseudoaneurysm, so this is basically a rupture which has got restricted by the pericardium. So this wall is composed of thrombus and pericardium, and there is still high risk of free rupture. But free rupture of true aneurysm is reported in very few. Maybe we can count on fingers that rupture of a true aneurysm occurring. But pseudoaneurysm, they have a wide propensity to rupture, and they always have a narrow base. So this is just for completion sake. We all know this thing. There's another classification given by Donato based on their angiographic appearance on the 30-degree right anterior oblique projection. So here they have 3 types. Type 1 is a true aneurysm. We can see in the picture. Here we can see both the. I hope my cursor is visible. So here both the boundaries are visible. So geometrically 2 systolic borders are seen, where there is abrupt change from thick myocardium thinned out scar. So we are able to see both the boundaries in this. So this is a type 1 aneurysm, which is a true aneurysm. In type 3, we find that LV systolic border is not found. So shape is without any borders. That is, whole of the ventricle has become thinned out. So this is a subset which we call, roughly speaking, dilated cardiomyopathy, where whole of the myocardium has got thinned out. So this is the subset where we go on for heart transplant and other things more than surgical ventricular restoration earlier. But now they have, we'll see how this thing is significant in coming slides. And then type 2 is intermediate between the two. The shape is characterized where only one border between the thickened and thinned out myocardium is visible, other border is diffuse. So this is intermediate between type 1 and type 3. So earlier studies were telling that when we have a type 3 disease, the process which we call ischemic dilated cardiomyopathy, here procedures relating to surgical ventricular restoration are not effective. That was the earlier understanding. And most of the things were offered to type 1 people. But there are multiple studies now, mostly by this group and then by others also. And they have said that surgical ventricular reduction can give significant improvement in cardiac and clinical status in all the patients, regardless of the shape, what is the shape of the aneurysm. And they have found that there is higher mortality mortality in types 2 and 3, but it is not significant. The mortality is also almost same in all the types. So all the patients where we have a dilated heart, if they are provided they are satisfying all the other criteria, surgical ventricular restoration can be offered. And ischemic dilated cardiomyopathy are not just true aneurysm, but can be not only the true aneurysm, but ischemic dilated cardiomyopathy can also be treated by surgical ventricular restoration. So this group in 2019, they have given this study. So earlier surgery was offered to only type 1. This is long back, not in nowadays, because this is already published in 2009. But before this, these few studies, the understanding was that surgical ventricular restoration can help only those patients where we have a well-defined border, which can on the angiogram. But now even dilated cardiomyopathy patients, they have been found to respond well, and the mortality is not different. Then comes the etiologies. So true left ventricular aneurysm, 95% of them occur because of myocardial infarction. Other causes are also there, which include trauma, Chagas disease, sarcoidosis, and congenital left ventricular aneurysms. These are the reasons for true left ventricular pseudoaneurysms. 95% again they are occurred due to coronary artery disease because of the contained rupture. But other causes include submitral rupture, which may occur after very overzealous decalcification on the mitral annulus during mitral valve replacement. Some of the septic pericarditis patients, they develop a false aneurysm. A previous surgery on the aortic valve also can give rise to pseudoaneurysms. And in the older series, after the transapical transcatheter aortic valve replacement, there have been reports of pseudoaneurysm occurring at the apex. So then, according to location, so what are the locations? So this is the division. How on the right hand of the view, we'll describe the location. So anterobasal, these segments we rarely find any aneurysm. Then anterolateral and apical areas. So these are the areas where aneurysms are most common. Then comes the posterior and inferior segments, where mostly aneurysms are false aneurysms. And whenever aneurysms are present on the inferior aspect, since the papillary muscles are there in that area, so they lead to so much distortion that we find mitral regurgitation associated. So 85% of the aneurysms are either anterolateral or apical, and they are generally due to occlusion of left ventral descending artery, and concomitant absence of collaterals. Around 5 to 10% are either posterior or basal. they are generally associated with right coronary artery disease, and less than 5% are lateral. Almost all the lateral aneurysms are false aneurysms, and 50% of posterior or inferior aneurysms are also false aneurysms. So why we need to know this? Because the management is different for based on territories. So true posterior, whenever we have a true posterior left ventricular aneurysm, they will always be associated with mitral regurgitation because it leads to distortion of the submitral apparatus. So what are the factors which contribute to left ventricular aneurysms? So it is a very important, the first point is the most important point. We have to have preserved contractility of the surrounding myocardium. Why? We will see when we are seeing the pathophysiology. So when the surrounding myocardium is having, this is actually effect of remodeling occurring on the cardiac muscles. So whenever we have a surrounding area of normal contractility, that is the most important thing for having aneurysm development. And then it has to be a transmural infarction, because by definition, there is no muscle present in the area which is aneurysmal. Then we don't have any collateral circulation. Reperfusion is delayed. That is a risk factor. Then we have to have elevated valve stress. We'll see in the pathology how this is important. Hypertension is one very important risk factors. So mostly it is seen in people who have hypertension, and then valve thinning and ventricular dilatation. These are the risk factors. So good control of hypertension has led to decrease in incidence of true left ventricular aneurysms in current series, recent series. So in the pathophysiology, we have two separate phases. First is early remodeling, and second is the late remodeling. So immediately after acute infarction, we have an infarct zone which is thinned out, and the process is called infarct expansion. So in infarct expansion, basically that area which has thinned out and now getting replaced by the fibrous scar is less tensile in its less strength, has less strength in the tensile strength, so that area it dilates. And once this dilation progresses further, other remodeling things, cardiac remodeling effects occur, and they change the shape to a spherical ventricular shape, and the whole of the tissue is replaced by the uh, fibrous tissue. The things which occur more commonly are increased apoptosis and diffuse myocyte hypertrophy in the associated area, and it changes the shape from elliptical to spherical configuration. So there are involvement of extracellular matrix proteins. There is involvement of collagen synthesis and metabolism pathways which lead to all this remodeling. And there are some neurohormonal changes which occur. So this is a very busy slide, and it shows how early remodeling and late remodeling occurs. So in early remodeling, which occurs immediately after the myocardial infarction. So we have infiltration with neutrophils, then matrix metalloproteins and extracellular matrix, they get activated. They degrade all the collagen which is present in the cardiac muscles, and this leads to myocardial slippage. So this is the buzzword or keyword, myocyte slippage, that leads to thinning and dilatation. Because of this phenomena of myocardial slippage, there is thinning and ventricular dilatation, and this ventricular dilation leads to increase in wastage. That further it leads to a vicious cycle, and this to dilation of the ventricle. This dilatation of ventricle leads to certain adaptive phenomena which actually become counterproductive in long term. So that adaptive phenomena is one, release of noradrenaline. So initially that noradrenaline which is elevated, it causes increase in the cardiac output and tries to compensate for the problem which is occurring. But the adverse effect of this elevated plasma norepinephrine is hypertrophy of the cardiac muscle. This hypertrophy occurs in the area away from the area where problem has occurred. So we have an area which has got infarcted, and now whatever remodeling is occurring, half of it is happening in the infarcted tissue, where we are getting it replaced, the muscle is getting replaced by fibrosis, and a lot of things are occurring at the area which is away from the area in concern. So this increased norepinephrine leads to myocardial hypertrophy. Same way, there is activation of renin-angiotensin mechanism. This leads to increase in angiotensin. Angiotensin is a very strong stimulator for myocyte hypertrophy. So we have a hypertrophy of the myocytes. Again, decreased cardiac output leads to increase in the atrial natriuretic peptides and BNP, and these levels will lead to increased sodium and water retention and decreased volume and systemic vascular resistance. So these are actually adaptive mechanism which is trying to maintain the cardiac output, but then this ANP and BNP will again release endothelin, will cause the release of endothelins, which will lead to myocyte hypertrophy. So this is actually an adaptive mechanism which has gone berserk and causing this myocyte hypertrophy in the area which is away from the area of scar. Same way, we have transfer TGF beta 1 release, which causes activation of ACE inhibitors, TGF beta inhibitors, then fibroblast gets. So now this thing, angiotensin and TGF beta, they all lead, and angiotensin convert enzyme, they all cause stimulation of the fibroblasts, and then the matrix collagen is replaced by fibrous tissue, and now we have a rate remodeling in fibrosis. So there are two things occurring with the myocardial infarction. One, the area away from the area of injury, we have myocardial hypertrophy, and area where the insult has occurred, we have fibrosis. So now we have area which was diseased and which was infarcted has got fibrosed, and area which was away from the infarct is now getting hypertrophy. So these two things lead to problems further that we'll see later. So in the multiple choice questions, these things can come. And why I have kept this busy slide, because these are the areas where we can have some pharmacological intervention. So that is why in the cardiac failure we have role of ACE inhibitors. So we know that ACE inhibitors are known to prevent the myocyte hypertrophy which occurs with the modeling. So ACE inhibitors are known to cause reverse remodeling. Same way, angiotensin receptor blockers, the endothelin blockers, they are still in the research phase. We don't have any clinically used things. ANP and BNP, we know that if these things are increased, they are associated with adverse remodeling, and then chances of hypertrophy is more. So in short, whatever we have seen, infarct expansion occurs, thinning and regional expansion that occurs within 1 day. Then global LV dysfunction occurs by day 2. We have myocyte slipping, which leads to lengthening of the myocytes. So, and further, this slippage leads to thinning of the ventricular wall. This thinned out wall is less pliant and it enlarges with stress. And then we have inflammation and resorption of necrotic tissue, dilation and resetting of LV. Death occurs in the late phase. We have myocyte hypertrophy, which occurs away from the area of injury, and then finally, eventually, we have the loss of myocytes in the infarcted area, and they are replaced by fibrosis and collagen in the interstitium. What are the neurohormonal changes occurs? These things are important because all our pharmacological methods of preventing a left ventricular aneurysm or preventing a late remodeling phase or promoting the reverse remodeling are targeting this. So we have noradrenaline, which then we have ANP, and both the levels decreasing. If we have a post-operative level of ANP and BNP decreasing, they are lower levels, they are associated with better prognosis. Same way we have angiotensin, which is increased in this patient, and it is a very potent stimulator for fibroblast and muscle hypertrophy. And we know that aldosterone, we know that interleukins, TNF alpha, endothelins, and prokinetins, all levels are increased, and their increased levels are associated with poorer prognosis. Clinically, we use only anti-proBNP as a marker. If it is increased, it shows that patients have a propensity to have a poorer prognosis. Clinically, still interleukins and TNF alpha and endothelins are not used, but they are potent areas of research where we can have some drugs which will help in preventing this adverse effects of adaptive mechanism or remodeling. So blockage of endothelin in animals, they have already proved that it improves the effects of remodeling, but still we don't have any clinically used or FDA approved drugs now. So what are the changes on the hemodynamics? So thinning of the infarct area. So there is loss of contractile muscles. So obviously it will decrease the cardiac output. Then we'll have compensatory hypertrophy of the remaining left ventricle, which tries to increase the cardiac output. So balance of the compensation. So whatever is the residual or remaining ejection fraction, remaining cardiac index, that also decides the outcome. So whatever the balance of these two will decide whether patient will have a very severe clinical presentation or milder one. And all these things lead to increase in the myocardial oxygen demand. So already we have a disease where the coronaries are affected and we have less blood supply, and this adrenaline will increase the myocardial oxygen demand. The compensatory hypertrophy, which is occurring in the surrounding muscles, that also increases the myocardial oxygen demand. We have a sac of aneurysm, aneurysmal sac is formed. So whenever heart contracts, some of the output goes forward and some of the output energy is wasted in the blood going into the aneurysmal sac. And since the wall tension is increased, we have a poor diastolic filling. So some of the energy is lost to compensate for that. So myocardial oxygen consumption is increased in a myocardium which is getting less oxygen due to decreased blood supply. So all these things lead to these hemodynamic changes. Now this is an important concept to understand what happens with the myocardial shape changes. What is the effect of change in shape when it becomes spherical? What is the problem? Why all hairs lose? So basically, initial response of LV dilatation is adaptive. It helps the heart in increasing the cardiac output. So we know this is the Frank-Starling curve and everyone can understand. So whenever we increase the end diastolic volume, the stroke volume increases. That is whenever we stretch a cardiac muscle, the longer the initial length, stronger is the force of contraction. So whenever the left ventricle dilates, it increases the force of contraction, and that's how stroke volume increases. So that is the initial phase. But there is a limit after which this curve flattens. So after that, further increase in the length of the muscle is not going to increase the force of contraction. So further increase in the end diastolic volume is not going to help in the forward cardiac output or stroke volume. So we reach a phase where this Frank-Starling law is no more followed, and now comes the place where Laplace law is followed. So here we can see if this is a balloon which we are trying to blow, since the cavities are in continuation, whatever is the pressure in this large area will be the same in the small area also. So both the areas will have same intraluminal pressure, but the tension which is present in the area which is small, this is common understanding. We have a balloon and we are trying to blow. When we try to press the balloon, the area which is large, it will be tense, and area which is small, which is not yet inflated, will be soft. So that is what is Laplace law. So as the left ventricle dilates, it has more and more wall tension. So a myocardium which is poor in contractility, which is thinned out, and which has lost all its viability, now it is stressed. Now it is subjected to higher wall tension. So that leads to adaptive changes also, and physiological changes also, and mechanical problems also. So this is a small understanding why our heart is in a conical shape. So we have read in our books, we see raindrops are always round. So for a given amount of volume, we know this from our physics. If we don't know, we just need to remember or understand that a circular shape or a spherical shape is energetically or thermodynamically most stable shape. So surface tension is least for a given volume. If we have three shapes, the surface tension is least in a sphere. So a sphere is literally speaking, or roughly speaking, a most stable form. So a sphere requires the least form of energy to maintain the shape. So if we have the given volume, the sphere, in the sphere, the wall tension will be less. But suppose we have to decrease this volume. In that case, a tubular shape is better. It will be able to give good contraction, good intraluminal power. So our ventricular configuration is basically a compromise between a spherical shape. If the heart was spherical totally, it will require a lot of energy to fill it. So diastolic filling will require less energy. So if heart was a sphere, the filling of the heart would have been very easy if it is spherical. But then if it is tubular, contraction will be able to increase, provide better output, better intraluminal force. So our ventricular configuration is a compromise between a spherical shape, which will lead least energy for diastolic ventricular filling, and a tubular shape, which will permit maximal conversion of systolic myocardial muscle tension into intracavitary pressure. So if our heart was tubular, it will be able to generate more forward cardiac output, and if our heart was spherical, it will be able to fill very easily. So we need both. Our cardiac output, it has to fill, then only it will empty. So that is why our heart is a conical shape, which is a compromise between energetically best diastolic function and energetically best systolic function. So it's a compromise of diastolic filling and systolic emptying. That is why our heart is a conical shape. So what happens in aneurysm? Then this is second this thing. I don't think we need to read the whole article. This is article by Dedenoto again. They have studied a sphericity index. So a sphericity index is a ratio between length and breadth of the cardiac this thing. So when the heart is spherical, and when the heart is conical, and when the heart is round, what happens? So for every 15% of fiber contraction, normal short to long axis is about 0.5 and ejection fraction is 62. If we just change it, same fiber contraction to long axis and short axis becoming equal, the ejection fraction will fall 50%. If the same thing we increase it, the ejection fraction will become 80%. So if the sphericity is increased, the ejection fraction will fall, and if sphericity decreased, it will increase exponentially. So that is the effect of shape. So our conical heart is a compromise of the two things, and that is why maintaining the conical shape of the heart is very important, because it will be thermodynamically or energetically the best compromise between systolic emptying and diastolic filling. So that is the reason left ventricular aneurysm we have some problems. So what happens in patients with left ventricular aneurysm? Heart tries to preserve its energy. So now the heart shape, heart muscle strength has lost. So to improve its diastolic filling, it tries to acquire a spherical shape. It tries to become rounded so that it is able to fill. But this rounding will actually lead to poorer emptying, and that is the problem with left ventricular aneurysm. And all our management strategies are targeted at maintaining a conical shape of the heart. So what happens to left ventricle and what happens to the right ventricle? Effectively, left ventricular function is decreased. That is obvious because cardiac muscle mass has got lost. If I have not written the reference, this is a study by De Donato only. So if the more than 20% of left ventricular wall is affected, we'll have a congestive heart failure. And if more than 40% of the left ventricle is affected, we'll have immediate shock. And there is presence of adjacent left ventricular muscle hypertrophy, which tries to maintain the balance. On the right ventricle also, all the things are happening in the left ventricle, but still we have right ventricular dysfunction in patients with left ventricular aneurysm. The reasons are that there is septal akinesia or dyskinesia, which is counterproductive. Then we have increased pulmonary artery pressure because of pulmonary artery hypertension, which is seen in patients with acute LVF or acute MI. So this also decreases the right ventricular function. We might have right coronary artery disease itself, which is attributed to right ventricular distension, and that enlarged left ventricle, it pushes the the septum towards the right, and that has a tamponading effect on the right ventricle. So this leads to poor RV function. So we have problem in the area where we have pathology, we have problem in the area away from the pathology, and we have a problem in the left ventricle itself where we had trouble. So all these things lead to problems, and that is why it needs to be addressed. Next comes a natural history. So what is the natural history? So whenever we speak of natural history, that means we are speaking what will happen to an individual if that patient is not treated. What is the course of disease if there is no treatment provided, or only medical treatment. Some of the studies have studied only medical treatment. So we are finding an old study, 1979. So all our natural history studies are actually old studies, because nowadays we don't leave anyone untreated. We give treatment to all the patients. So this is a study by Grondin et al. Published in Journal of Thoracic Cardiology, JTCVS, in 79, where they had studied 40 patients who have, please don't try to read this, I have summarized all these things for us. So here they have studied 40 people. What are the silent reports from this? So medically treated for this group A is the patient who was asymptomatic, and group B was the patient who had symptoms at presentation. So medically treated asymptomatic patients have excellent 10-year survival. So we can see the 10-year survival in those patients who have LV aneurysm detected angiographically and presented without any symptoms. They have excellent 10-year prognosis. But those patients who had symptoms at the time of presentation, they had a very dismal outcome, only 46% 10-year survival. Overall, whole of the group had around 66% survival. So they concluded that mere presence of left ventricular aneurysm is not in itself indication for surgery, because those patients who are asymptomatic at presentation, they are doing equally well without any management. So that's why if any patient we find a left ventricular aneurysm, we need not operate on all the patients. And what from their study they found that most valuable indications are those patients who have incapacitating angina or refractory congestive heart failure. So patients who are frankly symptomatic, they would benefit from this surgery. This is an old study in 1979, and there are other studies which have actually contradicted their findings. But this study is quoted at all the places. We'll see the later studies also. The second one was coronary artery surgery study. Here also they studied almost 1,136 patients with left ventricular aneurysm, and they tried to find out what happens to them who are given medical treatment only versus surgical treatment. So again, it's in true sense, it's not a natural history series, because here the patients are getting medical management, and we are comparing the medically and surgically treated patients. So here what they found, that patients who had aneurysm, they had a poorer survival compared to those patients who had coronary artery disease but no aneurysm. So all these patients had coronary artery disease. Those who had aneurysm, they had a poorer prognosis compared to those who did not have coronary artery disease. And probably this was statistically significant also. P value is very less. But then they stratified this according to left ventricular dysfunction and functional impairment. So NYHA class and left ventricular residual left ventricular function, when that was adjusted, they did not find any difference between survival of patient with aneurysm or without aneurysm. So that means if we take into a consideration how much is the LV dysfunction associated, there's no change in survival. So again, this study was also pointing to the finding that mere presence of left ventricular aneurysm is not going to change the outcome. So mortality group with primarily related to age, left ventricular function, and clinical severity of heart failure. So this is what was the physiological effect of this catastrophe. That is the deciding factor. So older age, left ventricular function, and severity of heart failure was actually guiding factor. And presence of aneurysm does not independently alter survival. That was their conclusion. So they found out in this study what are the major causes of morbidity or mortality. So patients who have arrhythmia, who have heart failure, and who have recurrent myocardial infarction, those are the patients who had more morbidity and more mortality. So this is again another benefit of studying the natural history. We know that who are the patients who will perform poorer, and those are the patients we'll try to address surgically or medically more. So any patients, now this gives us indication for surgery in patients who have left ventricular aneurysm. So patients who were symptomatic performed poorer. Patients who had arrhythmia, who had heart failure, who had recurrent MI performed poorer. So these are the patients whom we should offer the surgery. That is the benefit of giving studying the natural history. So again, they have given people who perform poorly, older people, the people who have larger left ventricular aneurysm, people who have poorer left ventricular residual function, any people who have left ventricular end-diastolic pressure which is higher, and now we have this thing, presence of asynergic system segments. So this is one new finding they have given, that any patients who have akinesia or dyskinesia, they are the poorer performing people. Functional impairment of CCF, number of vessel disease, mitral regurgitation, and ST gallop. So these things they found from the Cox analysis, that these are the factors which are associated with poorer prognosis. So these are the people whom we should be addressing surgically or medically more aggressively. So these are the natural histories. So from natural history studies, we'll find what are the indications for surgery, and now we need to know clinical findings. So angina or dyspnea, which persists long after myocardial infarction, is the most common feature. So presentation will be a person will give a history of MI which was treated or not treated. Then for transient period, generally they become asymptomatic after management for few days, but these people, this dyspnea or angina is persisting long after the myocardial infarction, they continue to have problems. So presentation is congestive heart failure with a history of MI generally. More than 50% of these patients will have multiple vessel disease on the coronary, and up to 1/3 will have an intractable ventricular tachycardia. So patients coming with recurrent palpitation, recurrent syncope, stroke, that those are the people who are likely to have left ventricular aneurysm. Other arrhythmias may also be present, and they will increase the symptoms. Up to 50% of these patients will have thrombus in the intracavitary thrombus. But just presence of aneurysm is not indication for anticoagulation, because only 20% of those who have a thrombus will develop thromboembolism. So unless we have a documented mural thrombus, we did not give anticoagulation to all patients with LV aneurysm. We know that more of them will develop thromboembolism thrombus later. But unless we have a documented thrombus which is large and which has embolized, we need not give blanket treatment of anticoagulation to all the patients, because overall risk of thromboembolism is 0.3% in whole of the patient. So long-term anticoagulation indicated only those where we have mural thrombus. Then clinical findings. So we may have diffuse sustained apical systolic thrust or double apex. We have third and fourth heart sound because these heart are enlarged and they have CCF. Apical pansystolic murmur may be present if we have mitral regurgitation, and other signs of CSF like pedal edema, elevated JVP, and those things are obviously present. So this regarding the clinical finding. ECG, again, a persistent ST elevation is very commonly seen in patients who have left ventricular aneurysm, and it is one pointed towards the diagnosis. in echocardiogram, we'll find an aneurysm or a pseudoaneurysm. So here again, we see this is a small neck and a large area which is restricted by pericardium. This is pseudoaneurysm, and whole of the wall is bulging. That is a true aneurysm. So echocardiogram is required. It is probably most of the time first investigation which gives us a diagnosis. Here things we're supposed to see in every patient where we have left ventricular aneurysm. Things we are supposed to see: how much is the involvement of the myocardium, how much is the right ventricular function, how much is the mitral regurgitation, how much, which are the segments which are involved, whether it's an anterior aneurysm or a posterior aneurysm, because all these things are going to change our management. And now tissue Doppler is available. We must always find what is the left ventricular end diastolic pressure, what is the filling pressure. We'll get that idea from the echocardiogram itself. So these things must be seen when we have the echocardiogram. And gold standard for diagnosis is left ventricular aneurysm. So this is a posterior basal posterior aneurysm. This is an anterior aneurysm. These are rare nowadays. We don't find such big aneurysms nowadays. Cardiac MRI. So this is once place where cardiac MRI has an important role. We must do cardiac MRI before undertaking surgical ventricular restoration for a patient with CHF, because it will give us best quantification of involved muscle mass. It will give an idea of proposed whatever segment we are going to resect by during aneurysmectomy or surgical ventricular restoration. So on the MRI, we must try to find out how much area we are going to resect, because that is going to finally affect our management. PET scan or thallium scan is done nowadays. So we must not resect an area which is hibernating. That is a criminal offense. If we have a heart which is dilated and we are going to do a surgical ventricular restoration, we must not resect area which is hibernating, because that area is the area which is going to improve after revascularization. So resecting an area which is live is a criminal offense. So that's why a nuclear scan must be done in all the patients, and we must find out, quantify how much is the involvement. And only those people where left ventricular end systolic index is more than 60, we'll see what is that. And where we have more than 35% of involvement, those people are generally improved with all the surgical techniques. And obviously coronary angiogram has to be done. We have to find the culprit patients which are to be revascularized. So now coming back to surgical indications. So what are the guidelines? So both the guidelines, European Society of Cardiology and American Heart Association, they say surgical aneurysmectomy does not seem to benefit. Surgery may be considered in patients who have large aneurysms, uncontrolled heart failure, or recurrent ventricular arrhythmias which are not treated by ablation. That's what a European Society of Cardiology says. Same thing is said by ACC/AHA guidelines, American Heart Association, that surgery for left ventricular aneurysm after stimulation is rarely needed, and it should be considered for treatment of heart failure, ventricular arrhythmias which are not amenable to drugs or radiofrequency embolism, and the new indication they have given recurrent thromboembolism despite appropriate anticoagulant therapy. So from again the guidelines are telling large aneurysm, uncontrolled heart failure, recurrent ventricular arrhythmias, and recurrent thromboembolism. These are the only indications for undertaking surgical ventricular restoration. In addition to coronary artery bypass grafting, what they mean is this is about surgical ventricular restoration. Obviously, if the patient has a vessel which is in the viable area of myocardium which is diseased, and vessel which is diseased, so obviously that patient will be offered coronary artery bypass grafting. This is, they are speaking about surgical ventricular restoration. So clear-cut indications are large left ventricular aneurysms which are associated with angina, congestive heart failure, recurrent ventricular tachycardia. Risk of late rupture is commonly seen in those patients who have pseudoaneurysm. Small left ventricular aneurysm, whenever they are undergoing any surgery like coronary artery bypass grafting, they may be operated. But we should avoid this in patients who have diffuse hypokinesia and patients who have severe LV dysfunction, because they might be better served with transplantation. So this is indication which is given our convert documented expansion or large size, angina, congestive heart failure, arrhythmia, rupture, pseudoaneurysm. Pseudoaneurysm by de facto indication for surgery. Any pseudoaneurysm must be operated because chances of rupture are very high. Congenital aneurysms, they also have problem. Patients who have embolism, they are class 2 recommendation for operation. What are the contraindications where we will not operate on the patients? So very poor anesthetic, obviously a patient has multiple comorbidity, it is a morbid process, then those patients will not be operated. Any patients who have a very poor resting cardiac index, they are relative contraindication for surgery. Whenever we have a non-transmural myocardial infarction, so by contraindication of surgery, by surgery, we are speaking of surgical ventricular restoration. We are not speaking of coronary artery bypass grafting. We are speaking of surgical ventricular restoration. So any patient who has very poor anesthetic risk, poor resting cardiac index, wherever we have a non-transmural myocardial infarction, that means there must be some viable myocardium in that area. Those patients are not candidates for surgical ventricular restoration. And most important, presence of hibernating myocardium. Any patient who has a hibernating myocardium must not be operated. It's a criminal offense, taking out that muscle which would have resuscitated by reperfusion therapy. So presence of hibernating myocardium is definite contraindication for ventricular restoration surgery. So to be worthy of operation, a dyskinetic or akinetic left ventricular aneurysm should significantly enlarge the left ventricular end systolic volume index over 80 milliliter per meter square, and end diastolic volume more than 120 milliliter per meter square. That is the critical volume, and we have to bring that back to 50. That is the normal. So this is again, I have not written the reference. I will send it on the group. So these are left ventricular end systolic volume index is to be around range of 80 to 120. And here, this slide also tests why stitch trial failed to show any benefit, because many of those patients who were operated in the stitch trial, they had left ventricular end systolic index less than 80 million, and then improvement was not less. They did not achieve that target of 50 ml per meter square. So that was not. So these are the people who will be benefited by surgery. So basic considerations, we have to double venous cannulations. We have to avoid handling the heart too much, because that will remove the clot and dislodge. Most of the anterior left ventricular aneurysm, we will try to revascularize the left ventricular descending artery. So incision is always parallel to the left ventricular descending artery. Posterior aneurysms, we generally try to put a patch, and they generally incision is parallel to the posterior descending artery. But sometimes we can take a transverse incision also. We have to take care we do not damage the papillary muscle. So what are the surgeries which can be offered to patients with left ventricular aneurysm? So we have two categories: linear reconstruction, where we have plication and linear repair and other things. And then second one is geometric reconstruction, which includes circular patch, endoventricular patch, or direct reconstruction using multiple concentric pulse sticks. That is the McCarthy's technique. We'll see what is that. So these are the two basic types of operations. One is linear reconstruction and one is geometric reconstruction. We'll see what are those. So this is again reported in American Journal of Pathology long ago. So this third diagram which we are seeing is linear repair, where we are just cutting the involved muscle and sewing it. So this is everting the edges. So we see that left ventricular end cavity size is becoming small, and we are not able to manage the elliptical shape also. And then geometric repair, where we are everting. So cavity size is not decreased, and we are able to attain the conical shape also. So this is the difference between the two techniques, and that is why we have a DOR procedure or other procedures being done in longer proportions in patients with left ventricular aneurysm now. So basic difference is whatever is remaining after the procedure is important. So plication is done only for aneurysm which are very small. So here the aneurysm is not open. Without opening, just 2 layers of running sutures are put so that aneurysm becomes small. So this is only for very smallest of the small aneurysms where there is no thrombus, and then it does not get rid of the tissue which is diseased. The dead tissue is still there. We have just made the cavity smaller. So this is just a process done for very small aneurysm when we are operating on the heart for some other pathologies. So this is just mentioned for completion's sake. Then second one is linear closure. So here what is done, that aneurysm is open. This is a very simple and easy surgery. We have to open the aneurysm, remove all the thrombus, and then suture the thing between the two felts. And it looks very messy, but it's a very easy surgery to do. So basically this thing is placated. We have to take deep suture with a big needle and 30 prolene. And this thing, we have to use tissel or any of the sealants to compare the suture line. So this is suitable basically for anterior aneurysm. Why it is not suitable for posterior aneurysm? Because we'll have to resect a lot of muscles. So it will lead to mitral regurgitation later, because it will cause a lot of distortion in the shape. So this is suitable for anterior aneurysm. Benefit of this surgery is we can simultaneously do coronary bypass grafting of left ventral descending artery. So LAD can be revascularized. For posterior aneurysm, less useful, but still used. But the problem with this thing is we are not excising whole of the akinetic myocardium. Some of the akinetic myocardium and septum are left behind. So they will contribute to the poorer left ventricular ejection fraction. And then whatever the separation between the septum and the lateral wall, that is lost, because so this is the area. So whatever the separation between the septum and lateral wall, that is lost. So that leads to poorer ejection fraction in post-operative period. And then shape of the left ventricle is not maintained. So we are not achieving the complete conical shape by this process. So this is preferable to endoventricular patch plasty in those patients who have very large aneurysms, where we can resect and find out, or aneurysm that lack well-defined border. If we do not have good defined border, we will not be able to perform the left ventricular restoration or DOR procedure. We'll see why that is there. So whenever we do not have a very well-defined border, or whenever we have a very large anterior aneurysm, in those patients, linear closure may be preferable to endovascular patch plasty. Other places we still by default the treatment of choice will be DOR procedure. Then there are certain modifications of linear closure. So this is a Stoney linear closure. This is just mentioned for completion sake, where they have again excised the area which is diseased and brought the edge to the area of on the septum where it is normal. So basically it extends the lateral wall to the healthy septum. So some of the akinetic area, this portion which was left in linear closure, is eliminated. So it leads to some better function. But then drawback of this surgery is we cannot revascularize the left ventral descending artery simultaneously. So this is very rarely performed. Then comes JATEN'S circular patch technique. So this is restoration surgery. This is basically done for posterior repairs. So here, this is shown for anterior. It can be done for anterior and posterior both. So here the area which is disease is removed, and then like septum is plicated. So we have septum plication. After removing the disease area, we put a circular suture. So that maintains the shape of the left ventricle, and after that we apply a patch. So there are two things are being done. One, septum is being plicated. So this kinesia of the septum is being taken care of. We are putting a circular patch, and on that we are circular stitch, and on that we are putting a diagonal patch. So this is maintaining the shape of the left ventricle also. So in the posterior aneurysm, this is a preferred technique, because if we oversew the wall of aneurysm onto itself, it will lead to distortion of the mitral wall, and it will lead to mitral regurgitation later. So that's why an adynamic patch in the posterior location is better than endovascular patch of DOR'S. So that is why it is a preferred approach in inferior or posterior aneurysms, and theoretically it can be applied to anterior aneurysm also, but rarely it is required. And again, the benefit, it reverses the left ventricular geometry and avoid the septal dysfunction. And one added benefit is on the posterior, when we are doing this thing, it leads to less mitral regurgitation. So circular patch plasty is a geometric surgery which is preferred in the posterior or inferior aneurysms, because it is more suitable for those locations. Then comes the DOR procedure, which is endoventricular repair, which is the treatment by default, treatment of choice in most of the aneurysms. So here we open the sac. So here we can see that all the trabeculations have got lost and it is a smooth muscle. So you open the sac, most of the time we'll have some clots which are removed. Then we have a very well-defined border where below this we are finding all the trabeculations. Above this it is all smooth muscle. So this is the scar and this is the myocardium which is either infarcted or which is healthy. So that is why we saw that linear closure is a preferred method where we do not have well-defined borders, because for doing this DOR procedure we need a well-defined border where we can put the circular stitch. So one bursting suture is put on this. This is called a fontaine stitch. So this will actually decrease the size of the opening, and it will help us achieving a geometrical shape. After we have done this, we tie this purse string. So this makes the cavity size smaller. So we should not be over enthusiastic and go on decreasing this size. So nowadays what we do, we put a plastic or a spherical this thing inside based on the body surface area and size of the patient, and over that we tie the suture and we know how much we need to tie. So that will help us maintaining the cavity. And what we spoke, that end left ventricular end systolic volume index should be around 50 milliliter per meter square. So that according to that we'll choose the balloon size and put it inside, so we'll know how much we have to tie so that we are neither less nor more. Then after we have tied this suture, the remaining defect, we have to put one patch. Once we have put this patch, now this patch is lying on the ventricular cavity that is overrun, and the remaining ventricular sac is oversewn over this. So this is what a DOR procedure. This also looks very messy, but it's an easy procedure to do, and it is a very rewarding procedure to do in patients with left ventricular aneurysms. So any larger aneurysms on anterior wall, this is a preferred procedure. It is suitable for anterior aneurysms. It's difficult to apply to posterior aneurysm, because if we do a lot of small that fontaine stitch, if we put on the posterior wall, this stitch will lead to distortion of the mitral apparatus and lead to mitral regurgitation. So that is why it is difficult to apply to posterior wall, but it is done. After the fontaine stitch, if defect is less than 3 centimeter, we can just close it without patch also. Some people do that, but putting a patch is always better because it maintains the shape of the wall. So for deciding the size, it can be customized using balloon forms or plastic forms. Target end diastolic volume index is 50 to 60 milliliter per meter square. So we have to achieve. So that size of balloon we'll put in the cavity and tie the fontaine stitch to know how much we are supposed to tie. It ensures the exclusion of the akinetic segments of the interventricular septum. So all the akinetic septum is now excluded because we have put the fontaine stitch in the area where we have the transition from the smooth to the trabeculation portion. So that means in the septum also, whatever was the non-functional area, that has gone away. And obviously it gives a better LV geometry. Here also, left anterior descending artery can be revascularized after the DOR'S procedure. So always CABG is done in association with this procedure. And whatever the patch we are putting, we are covering it with the aneurysmal sac itself. So this area is not exposed, so it will not get adhered to the pericardium or lead to any infection or any other things. So that is the process. Then there is a modification and endoventricular circular plasty by McCarthy. This is what we had discussed. So here, same thing, aneurysm is open parallel to the left anterior descending artery. We put a circular stitch and put another circular stitch. So this process benefit is some people who are experienced, they do it off pump also. They do it without cardiopulmonary bypass and without cross clamping the heart and stopping the heart. So you find the border where the LV, once you have opened, you will find that some area is contracting and the other area is not contracting. So we start putting sequential bursting over the external surface of heart without, if we are doing it off pump. If we are doing it on pump, we open and put one fontaine stitch, then LV cavity side, that hole becomes smaller. Then we put another fontaine stitch, 4 millimeter below this. So when area is than 3 centimeter, we can close it directly over it by this procedure. So we can avoid a patch. And some experienced people, they are doing it without cardiopulmonary bypass and without cross clamp. So this can be done when the septum and mitral valve apparatus is extensively involved. But by and large, when we speak of surgical ventricular restoration, a DOR'S procedure is the most commonly performed procedure, and it is probably easiest of them to do. Obviously, linear plication is more easier. There are some procedures, just I have mentioned for completion sake, capitonage by Carbral and Guillemets overcut angioplasty. I have mentioned them just for completion sake. Then some other things have been are being done. So this is a report we can find in the Journal of Cardiac Surgery, where people have used left ventricular assist device in association with patch closure. Somehow I don't have the diagram. So here what they have done on this patch, is this patch which we are attached on the this thing on the ventricular opening, that is used for attaching the heart med. So left ventricular assist device, and they have reported almost 144 patients where LVAD was done, and 80 of them, 75 of them had obtained. So this I have just mentioned for completion sake. Next comes, what is the benefit of doing surgery? So question is, does adding surgical ventricular restoration to coronary artery bypass grafting add to survival? Does it benefit the patient in the long term? So there are one trial, that is only one trial, which randomized trial, which is done on this subject, that is the STITCH trial. And there's a study, RESTORE study, which is a multi-centric registry where they have addressed this issue. Then this issue has been addressed retrospective. Actually, CAST study was not designed to study this question, answer this question, but they had done the data analysis on the patients because it was a large data, and they have come out with some conclusion. And there are some other meta-analyses which answer this question, whether we should just do a CABG or add surgical ventricular restoration to those patients who have left ventricular aneurysm. So STITCH trial was the only randomized trial. There were two hypotheses. So hypothesis 2 had studied those patients who had coronary artery bypass grafting with surgical ventricular restoration with coronary artery bypass grafting alone. This we have seen when we did our first session on coronary artery grafting on the session on evidence. But for completion sake and for quick revision, I'll go through all of them together. So STITCH trial, we had studied only patients who had coronary artery disease, amenable to coronary artery bypass grafting, and ejection fraction less than 35%. Hypothesis 1 studied whether adding coronary artery bypass grafting to medical management helps those patients or not. So they studied CABG with medical management versus medical management alone. In the hypothesis 2, they studied patients with CABG alone and patients who are undergoing CABG with surgical ventricular restoration. So question was whether adding surgical ventricular restoration to CABG helps those patients or not. Then they had a viability sub-study group also, where they studied role of SPECT or abdominal stress echocardiography or both in hypothesis 1 patient, that is medical management versus surgery, whether this helps or not. Then this study was extended, STITCH extension study, and 10-year results were given. I have been able to find only results, 10-year results of hypothesis 1. I tried to search a lot, so most probably it has not come. If someone finds, please inform us on the group. We will go through that. But 10-year results of hypothesis 2, that means surgical ventricular restoration, I was not able to find. So this was the hypothesis 1. Here, patient with coronary artery disease and ejection fraction less than 35%, medical management versus surgery and medical management. They found there was no difference with respect to death from any cause. That was the primary endpoint. But patient who had allotted to CABG had better secondary endpoints, that was death from cardiovascular causes or composite of death from any cause and hospitalization for cardiovascular causes. So they found that there is no survival advantage of giving CABG to patients who have poor ejection fraction. That was the 5-year results, and that was in contraindication to most of the studies that time. So there was no survival advantage, but death from cardiac cause were reduced and hospitalization for cardiovascular cause were reduced. So in this randomized trial, they found that there was no significant difference between medical management and medical management with CABG in the patients in the long term. This was 5-year result for the hypothesis 1. But and in hypothesis 1, they also studied patients with viability study. That was patients were given CABG and myocardial assessment was done with SPECT, abdominal stress echography or both. So they studied CABG versus medical management alone. So patient with myocardial viability had lower 5-year survival rate, but after adjustment for other baseline variables, this association with morbidity was not significant. So, and improvement with left ventricular ejection fraction was seen only in those patients with viability. So what was their conclusion? That assessment of myocardial viability did not identify the patients with a differential survival benefit from CABG. That means knowing whether this patient has a viable myocardium or not was not going to help. So we cannot have a patient with poor ejection fraction and do a viability study. Only those with viable myocardium you operate, and those without viable myocardium you don't operate. That was thrown out of the window by STITCH trial, viability study trial. Then they came with 10-year results, STITCH extension study. So in 10-year results, they found that CABG with medical management was better than CABG alone in those patients with ventricular dysfunction. So that is why we offer surgery to patients with poor ejection fraction. So in the examination, if there's a patient who has a coronary artery disease, LV ejection fraction is less than 35%, if they ask whether we are going to offer surgery to them or not, so answer is yes, we are going to offer the surgery. And what is the evidence for that? So STITCH extension study has shown that CABG is beneficial in those patients who have poor ejection fraction. So CABG in the long term gave survival advantage for the patients who have poor LV function, and it also decreased death from cardiovascular causes and hospitalization due to cardiovascular causes. So this is the evidence for offering coronary artery bypass grafting for patients with poor ejection fraction. In the long term, in the 5 years, they did not find any advantage, but at 10 years, they have found advantage. So same thing with 10-year study. In the viability study, they did not find any difference at 10 years also. So knowing viable or non-viable myocardium was not helping. So that was a digression from our current topic. Our current discussion was whether coronary artery bypass surgery helps to, adding surgical ventricular restoration to coronary artery bypass surgery helps these patients or not. So this was the second hypothesis which they tested, and their 5-year results were then. So patient with coronary artery disease unable to CABG and ejection fraction less than 35%. They found that they should have a dominant anterior left ventricular dysfunction, which is unable to surgical ventricular restoration. So they did cardiac MRI studies and PEC studies and found whether anterior LV dysfunction is present or not, and this thing can be resected or not. So they two arms. One was where CABG was done alone, and second one was where CABG and surgical ventricular restoration both was done. They did not find any difference in death from any cause or hospitalization for cardiovascular cause. This was the composite they found. There was a greater decrease in left ventricular volume with surgical ventricular restoration, but no better change in symptoms or exercise tolerance. So this study failed to show any advantage of adding surgical ventricular restoration to coronary artery bypass grafting. So STITCH 1 was the only randomized trial, and they concluded that adding surgical ventricular restoration to coronary artery bypass grafting, it reduced the left ventricular volume as compared to CABG alone. But this anatomical change was not associated with greater improvement in symptoms or exercise tolerance or a reduction in rate of death or hospitalization. So this is, both the graphs were same. So adding a surgical ventricular restoration to a CABG did not benefit either the long-term mortality or the hospitalization or the symptoms or the exercise tolerance. So STITCH 1 trial, hypothesis 2 were conclusively against using surgical ventricular restoration. And this was against our understanding of left ventricular aneurysms or left ventricular dysfunction or cardiomyopathy. So that is why it was very strongly contested, and there were a lot of literature criticizing this study. They concluded that anatomical left ventricular reduction has no effect on survival. So what are the pitfalls of STITCH trial? Why it failed to show a benefit which is very obvious on common sense? So there are multiple papers on this, by most of them by Buckber and his group, and why they made misguided calculations. We not go into the details. We just know that cardiac MRI, what the suggestions were given by those who the cardiac MR and quantification of ventricular volume should be done in all the patients before and after surgical ventricular restoration. This was not done in these patients with STITCH trial. And surgical ventricular restoration should be done only in patients who have larger hearts. In the STITCH trial, many of the patients' end systolic volume, average end systolic volume was less than 18 ml per meter square. So these patients were not bad enough to start with. We have seen in the natural history, it is useful for only those patients who have poorer function. So in the STITCH trial, many patients were not bad enough to start with. So that is why it failed. And then we must demonstrate that at least 30% reduction of end systolic volume has occurred to be beneficial. If the starting end systolic volume was 100 and we have been able to attain an end systolic volume of 80 only, that patient is not going to benefit. We have to reduce the end systolic volume by minimum of 30%, and based on multiple studies they have shown. So STITCH trial failed to show benefit because many of these patients did not achieve that criteria. So that is the reason STITCH trial was not able to find any benefits with surgical restoration or DOR procedure. Then there's the second study, that is a RESTORE study, RESTORE group experience. So this is a registry where almost 1,200 patients were studied, and they were examined for risk factors identification. So this study, RESTORE study, studied patients with anterior myocardial infarction and congestive heart failure, which were treated with surgical ventricular restoration. And along with surgical ventricular restoration, they underwent either coronary bypass grafting, almost all of them, mitral valve repair in few of them, and mitral valve replacement in another few of them. And then they find that overall mortality is 5.3% and 5-year survival 68%, which was a very good thing. And 5-year freedom from readmission for congestive heart failure was 78%. So here, since this was not a randomized trial, so they did not have any comparative group, but they said that overall mortality is also less. So this is not a procedure which is associated with high mortality. And then 5-year survival and freedom from the symptoms is very good, 68% and 78% respectively. So that is, this was in favor of surgical ventricular restoration. They found that it was associated with improvement in left ventricular ejection fraction. It decreased the left ventricular end systolic volume index significantly, and it significantly improved the NYHA class of the patient. What were the risk factors associated with these patients? So those patients who had very poor heart to start with, those patients who had age more than 75, and those patients who have a very dilated heart and poor NYHA class. So these are actually the patients who require surgery, and these are the patients who are higher risk also. So their conclusion was surgical ventricular restoration improves the ventricular function and is highly effective therapy in treatment of ischemic cardiomyopathy with excellent 5-year outcome. So if in the exam we have, or if we have a patient where we are going to discuss with him what are the options, we can quote that there are studies which have proved that this surgery is going to benefit you in the long term, and that is why we are going to offer this surgery. One particular finding which was there in the RESTORE study, they studied those patients who have dyskinesia versus akinesia. We have seen dyskinetic are those segments which bulge in systole, and akinetic segments are which do not move at all in systole. So they found that 5-year survival was better in those patients who had dyskinetic segments. They had 80% 5-year survival, and others had 65% 5-year survival, and it was significant. RESTORE study is probably only study which has reported this. So that is why this has been mentioned. It might click somewhere in our discussion. That this was the only study where we found that dyskinetic segments, they have better prognosis. Because other studies, they have shown if the patient has akinetic area, the 5-year survival is 69%, and those patients who have dyskinetic area, they have 5-year survival 54%. And if this dyskinesia is associated with poor ejection fraction, the survival is further reduced to 36%. So RESTORE study was only study which has shown dyskinesia is less dangerous. Otherwise, patients who have dyskinetic hearts, they perform poorer with the surgery. And as such, there have been no randomized trials which have addressed this thing. So for all practical purposes, if we have a patient who has dyskinetic myocardium, that patient is likely to perform poorer. Now, what is the effect of surgery on survival? Natural history. So CAS study, again, they have studied what is the influence of surgery. So when they studied, was undergoing resection, that means surgical ventricular resection, they found that 6-year survival was poorer. So here, those patients who have undergone coronary artery bypass grafting alone, they had a survival of around 78%. And those who underwent surgical ventricular restoration with CABG, they had a survival of around 60%. And this was actually statistically significant. But when they adjusted it again to the congestive heart failure and degree of congestive heart failure and other features, so they found there is no significant difference. So again, resection is not associated with poorer outcome. This was the study this was the conclusion of CAS study also, that if you are adding a surgical ventricular resection, this is not associated with poorer outcome. Poorer outcome is actually associated with a poorer state of the patient to start with, poorer LV function and more congestive heart failure. Those are the patients who will be associated with poorer outcome. The overall operative mortality in this CAS study was 7.9%, and it was 7% for bypass alone and 9% for patient with bypass and left ventricular surgical restoration both together. So overall mortality was also not very different in these patients. Then further they studied patients who had single or double vessel disease. Survival rates were similar for medically and surgically treated patients. So who are the patients who are going to benefit with adding surgical ventricular restoration? So single vessel and double vessel disease patients, they did not benefit. So only subset where they found there is a survival advantage was the patient with triple vessel disease. In patients who had triple vessel disease, surgery resulted in improved survival at 6 years. So we have seen the first graph. Here they said those patients who underwent resection, they have poorer 6-year survival. Overall group had a poorer 6-year survival, but even that was not significant when we added other features. And then they found that at least those patients who had a triple vessel disease, they had definite survival advantage. So any patient with triple vessel disease and having left ventricular aneurysm, now we have the second evidence for offering him surgery. First evidence was a RESTORE study, which showed that it improves survival. Then second study is CAS study, where they have shown that triple vessel disease and left ventricular aneurysm offering surgery is associated with better outcome. And we have one study which is opposing it, is the STITCH trial, but there is a lot of lacuna in the STITCH trial. That is why we are not considering that. So their conclusion was, again, overall there was significant improvement in survival in patients with surgical therapy. By surgery, they mean adding surgical ventricular restoration to coronary artery bypass graft. And it significantly reduced the symptoms of angina and use of cardiac medication. Symptomatic improvement is also there. Recurrent infarction was not affected. So adding surgical ventricular restoration has nothing to do with recurrent infarction. So improved outcome with surgery was seen in patients with triple vessel disease and those with moderate and high risk subgroups. So the patients who are high risk for surgery are the patients actually who get benefited also. So that is why higher risk is not to be considered as a complete no-no. So now we have two evidences which support surgical ventricular restoration. One is RESTORE study. Second is data analysis from the CAS study, and then drawbacks of the STITCH trial. Is one technique better than the other technique? We have seen that if we have a very large aneurysm, we'll prefer a linear closure. If we have an aneurysm where borders are not well defined, we'll prefer linear closure. And if we have a large aneurysm, if we have an aneurysm which is posteriorly, we'll use a patch technique and DOR technique wherever we are able to do it. So is one technique better than others? I have not made slides for this. Here they have studied most of the reports. They did not find any randomized control trials, but they had individual reports. So what they found that in initial years of surgical ventricular restoration, the geometric technique was definitely better. But later years of reports, both the techniques had equal results. So what they said, the advantage from geometric reconstruction techniques in terms of mortality was shown in some studies by an effect of learning curve. So actually we have a better understanding of the pathology and better post-operative and intraoperative management and better surgical this thing. That is why we have a better outcome with both geometrical thing and a linear thing also. So this question is not answered. So at present, it is not a one surgery fits all. It is a procedure which has to offered on the person to person basis. what are the benefits, hemodynamic outcomes of surgery? Does this give us a hemodynamic advantage? So this is a study. This was again old studies by reported in JTCVS, where they had studied effect of hemodynamics. I have just summarized. We need not go and read this whole article. So left ventricular end diastolic volume decreases. Ejection fraction definitely improves. Cardiac index, which was low to start with before surgery, it becomes normal. Mean systolic wall tension decreases because we have achieved a elliptical shift, so tension on the wall becomes less. So this translates into neurohormonal changes also. Obviously, the wall stress will decrease, so noradrenaline, angiotensin, ACE inhibitors, all those things which were angiotensin, all these things which were increasing, they will also settle down. Left ventricular end diastolic pressure decreases, so filling pressure of the heart decreases, so heart becomes the diastolic dysfunction goes off, and heart becomes more effective organ. Stroke work index increases. That means for adequate for unit of change in contraction, we are able to generate better cardiac output. Shape of the left ventricle becomes more elliptical, and that is energetically or thermodynamically more stable shape. And Frank-Starling curve. So we, from the plateau of the Frank-Starling curve, the heart goes towards the earlier phases where increasing the length is going to help the cardiac output. So this is hemodynamic outcome of the surgery. Then post-operative outcomes, just summarized. Operative mortality is now in range of 5%. 5-year survival is roughly 75%. Ventricular arrhythmia is seen in 15 to 20% of patients. So all these patients, all the indications for AICD and CRTD and CRT are applicable. So any patients who has survived this thing and 6 weeks, and if he has a QRS duration more than 150, so that CRT device is indicated and that will be given. Any patient who had arrhythmias, recurrent arrhythmias, and if AICD is indicated, that will be given. So ventricular arrhythmias 15 to 20%, renal failure in 3 to 5%, bleeding in 2 to 3%, stroke in 3 to 4%. It is more common in those patients who have thrombus. Obviously, left ventricle becomes more elliptical. One important thing in post-operative management, that post-operatively the size of LV cavity has decreased from initially. So stroke volume also decreases. So for maintaining the cardiac output, the heart is dependent on the heart rate. So cardiac output is maintained by increasing the heart rate. So beta blockers have to be avoided in the immediate post-operative period. We know that beta blockers prolong the outcome, prolong the survival in this patient. But whenever we have a surgical ventricular restoration, since the stroke, the size of the LV cavity has decreased and stroke volume has decreased, so cardiac output is maintained by increase in heart rate. So in these patients, initial few months or few weeks or few days actually in the immediate post-operative period and in the ward, we have provided beta blockers to maintain this thing. And a little bit of highest filling pressure will be required for initial few days for smoother recovery. So this finishes the surgery. Now some recent advances. So what are the percutaneous therapies which are available for this thing? So one is Bioventrix Revivent. It was actually earlier called PLICATION. This is a myocardial anchoring system, and parachute ventricular partitioning devices. This is a parachute device. And then we have cellular cardiomyopathy, PLASTY. So this is basically stem cell. In All India Institute of Medical Sciences, we all had a study which showed initial improving results, but it is not widely practiced. So yeah, either intracoronary, the stem cells are implanted, or intramyocardial injection are given. This can be done in the cath lab also, or during the surgery. So what we had studied at All India Institute of Medical Sciences, injecting the stem cells taken from the sternum of the patient and processed, and at the end of surgery we inject intramyocardially, and we found that ejection fraction improves better. So these things are not day-to-day life thing, but they are being researched and done. Then second is percutaneous devices which are used in late phases. We have ventricular partitioning device. This is the parachute device which sits in the ventricle, so changes the shape of the cavity to the elliptical form. So the adynamic segment of the heart is excluded. Now this device is also adynamic, but at least it improves the shape of the LV. So in filling pressure and other things decreases. So we have parachute 1, parachute 2, and parachute 3 trials, and they have shown promising results. And recently this device has got both FDA and CE certification for use in the patients. Then we have epicardioventricular restoration device, where we are doing the plication of the left ventricular aneurysm. This is revivent device, which was earlier called PLICAT. This can be done through a small left thoracotomy or percussion through the apex also. So this is the bioventric device, where device is put from one area of transition on the one wall to the area of transition on the other wall, and then comes back, and this thing is then plicated. So effectively we are achieving the linear plication with this technique. So only one, since this is being done percutaneously, it is beneficial. Obviously a DOR procedure would have been better, but then this is being done percutaneously without patient having to go through mutilating surgery. So that is why it is beneficial, and they have reported this thing, and this has got FDA approval. This is being done. This is second device, which is ventricular partitioning device. So this device is put either retrograde or antegrade method. That means it can be done through septal puncture through the veins also, or it can be done in retrograde manner for the femoral artery also. This device is put, and this is inflated in the left ventricular apex. So the there is a static chamber which is not contracting, and then there's a dynamic chamber which is actually communicating with the aorta and doing the work of the heart. So this is also being used in patients nowadays. There are some other techniques which have been deployed. So here septal occluder, that is HD device, implanted HD device. These two reports are from India. Basically they have been used for pseudoaneurysm, not for true aneurysms, where suppose this is the area of pseudoaneurysm, they just occlude that thing with a septal occluder. So that pseudoaneurysm is lying outside, and this can also be done percutaneously or through a thoracotomy. So pseudoaneurysm is just for mention for completion's sake. They are difficult to distinguish from true aneurysm clinically. We can find a to and fro murmur when the blood is going from the cavity to the pseudo cavity. Friction rubs can be present. A bulge will be seen on the lateral wall, and we'll find a narrow neck on the echo or left ventriculogram. So that is the diagnostic feature of pseudoaneurysm. And they have a very high propensity to rupture. So that is why they are indicated to be closed urgently. Techniques are similar to those techniques in free valve rupture. We have discussed this already in detail, and there are some percutaneous techniques also. If these patients are operated in time, we have a better survival. That is for next class. So this finishes our left ventricular aneurysm portion. I think there was one question on the chat. I can't see the chat now. Chat. There's
Sorry, we've been chatting on the side, so I'll give you the question. Can you hear me?
Okay. So that's, yes sir, that's presence of thrombus mandate surgery. Just mere presence of thrombus is not indication for surgery. And most of the time, if we are doing a coronary artery bypass grafting and there is a thrombus in the LV, we don't touch it. We touch it only if it's a very large thrombus. Just recently, we have operated on a guy who was just 34 years old. And he had one embolism in the month of, I think, April. That time was the lockdown time in the city of Meerut. He went to some place and their embolectomy was done. That time they detected a large clot in the LV, and he was prescribed anticoagulation. Somehow he did a silly thing and stopped this anticoagulation. He had another embolic episode. Second time he came, and this time we advised him actually surgery for removal of LV clot. He had no coronary artery disease, actually, just mild disease. This time he refused surgery. Third time he came with another clot, and this time he required an amputation also. This time we operated and removed the thrombus and did a plication because he had an aneurysm. So whenever we have a very large thrombus load, this particular guy, I should have shown the diagrams for this time. This particular guy, the clot was reaching up to the aortic wall. It was such a huge clot. Second time when he came, and which that time he went lama. So if we have a very huge clot, that might be an indication, but presence of a clot per se is not an indication. Suppose we are doing a CABG of a patient who has a small organized type of clot, we'll just give anticoagulation. But those patients will definitely be given anticoagulation, which is warfarin over and above dual antiplatelet for long term. Okay. If we are having other symptoms, then it becomes surgery. So parasite clot is not an indication for surgery. How parachute device is fixed to, how parachute device is shipped to switched. Okay. So here in parachute device, they have two inflatable things. One is for the whatever you call it base of the cup. So can you see this? This is the base of the cup. So this is also inflated, and that anchors the device to the apex. Okay, and then second cup is open. That cup forms as the boundary. So this is the fixation the thing base which fixes the thing to the LV.
Is it stitched by the any sutures or it's any vacuum mechanism?
No. It is just like our tower gets fixed by itself. So it does not need any suturing.
Okay.
It can be done totally percutaneously. Okay, sir. I think I don't think any indications for surgery in left ventricular aneurysm undergoing concomitant cardiac surgery. So if we have opened a chest and we are going to do a surgery, it's better to do at least PLICATION, at least linear PLICATION. So most of these patients, other surgery is coronary artery bypass grafting. So in those patients, if it is a large aneurysm, we would go on and do a PLICATION. But a small one, we generally leave it out because adding another 30-40 minutes does not help for a small aneurysm. So if they are large enough, then only we'll operate. Okay, sir. So questions also we have seen, sir. I'll stop.
Fantastic. Yeah, fantastic. Thank you.
It was a dry topic. Not much was there in this, but
it is important for the exam. That's the thing. You see.
Yes, sir. It might come as a short note or one clinical scenario.
No, MCQ will come out of the topic just discussed. So
yes,
particularly for the guys who are just going for exam, MCQ will come. So let me first stop recording. Pause.